Welcome to our webinar tonight. It's a Q&A session on the Medicare changes since July. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on tonight and pay respect to elders past, present and emerging. I'm coming to you from Enewan land, Armidale in the beautiful Northern Tablelands. Our presenters tonight are two GPs, Dr. Michelle Redford, who's also the Medical Director for the Primary Health Network, and Dr. Ashley Van Leeuwestyn. And Ashley has her own business called Better Billing, which has all your answers to MBS billing for GPs. So I will hand over to Ashley and we'll get started. If you have any questions, please type them into the question box and Michelle will read them out and discuss the question and the answers. We haven't got a huge amount of people on tonight. It would be nice to make it really interactive. If you're comfortable turning on your camera and your microphone, you can do that. Turn your camera on and then we'll know that you've got a question to ask and we can do it that way. But if you're not comfortable doing that, just type them in. All right, thanks so much. I'll hand over to you, Ashley.
Thank you, Jenny. Good evening, everybody. I'm Ash. I am, for those of you who don't know me, I am a GP that's based at Waratah Medical at Morisset, and I'm the owner and creator of Better Billing, which is an MBS education online platform that's both on demand and also provides webinar and support services like we're doing tonight. So this is the third and final of our series that I've had with our PHN around what the Medicare changes have looked like since July. And mostly around our new GP chronic condition management plan, a little bit about My Medicare. We've also done some work around the 10997 and 10987 item numbers. But tonight is really an open Q&A available for anybody who's online tonight, that we can kind of focus a little bit around what these care plan changes have looked like and then specific questions that you might have. So I'm just going to go through the screen for you. So the screen will not change tonight. So this is our base poster screen. And for those of you who may have already been to some of my webinars, you'll see that the GP chronic condition management plan summary is just on the right hand side. This is free to download in the resource section of my site. And this just gives you a little bit of a rundown of what actually the chronic condition management plans now look like. And essentially we've said goodbye to GPMPs and TCAs and their associated review item numbers, and they've now been replaced with what we call 965, which is the preparation for care planning or the new GP chronic condition management plan. And also our review number is now 967. You can see in the summary sheet as well what that looks like in terms of their video counterparts and what they're replacing. Just be wary tonight, like a lot of us, I have not changed my terminology as of yet around what care planning is. I still call them care plans. I will do my absolute best not to call them a GPMP, but care plans will be something I'll definitely use the words of tonight. So there's some other specific things that you can see here on the poster is the details of change. And so specifically around referring to our allied health colleagues. So GPs no longer have TCAs, which we need to initiate, which is honestly great for us from an admin point of view. And there's also no longer the need to have U+2 in the need for a team care arrangement. So those are now gone. Referrals are now done by more traditional referral letters rather than the old school EPC forms that we had. And then to access your allied health services, GP chronic condition management plans must be prepared or reviewed within the last 18 months. So patients can't just access services without being able to have their review or have their plan created quite recently. Then some mention on the My Medicare changes. So the reason why My Medicare is important during this time is that patients registered with My Medicare must have plans and reviews provided by their registered practice. So if they're registered elsewhere and they go to a new GP and haven't changed over their registration, completing a care plan or a 965 in this case would actually end up with an exception, which a lot of practices we're finding are starting to have. Unregistered patients, so patients who haven't registered elsewhere, are also able to continue to access their care plans through their usual GP and don't need to be exactly where they've been exactly one particular space, especially if they have not registered with any other provider with My Medicare. Other points will be in the future in July 2027, our medication review. Patients will need to have an active and chronic care plan to be able to access the DMMR. So that's something in the future to be wary of. Multidisciplinary care plan items have not changed during this time as well. So you can see here, I just put a little bit more information, and this is mostly specified for GPs and our allied health friends about what the referral process is looking like. So that the biggest changes for the referral process is, like I said, we don't have the EPC anymore, and a standard referral letter is sufficient. If you are looking for templates yourself that you'd like to use or want some inspiration, my site has free templates available for you to be able to use, and they're very friendly to be imported straight into best practice for your letter writer. Then in terms of minimum requirements for a valid referral at the moment, it's actually really not very much at all. And I think for a lot of our allied health friends, they're finding this quite frustrating. All you need is your referring GP's name, practice, provider number like a normal referral letter, the date of the referral, the duration of validity if applicable. So you don't actually need to say how long the referral is valid for, but the default validity is 18 months from the first service. There also does need to be clinical reason for the referral and relevant patient information. So there doesn't need to be any further attachments of care plans, etc., but there does need to be information that is relevant for the patient. So that might be their medical history, imaging, investigations that might be relevant. There is more flexibility for patients. So there is no need to actually name an allied health provider on the referral. You can provide the referral to your patient and say, find your favorite physiotherapist, or find your favorite podiatrist, whoever that might be. And there's also no need to specify a number of services unless the GP chooses to do so. And this is where a lot of us are finding we're getting a bit concerned. Some GPs are getting returned referral letters back from our allied health saying that they need to specify numbers of sessions. However, that is not the case. It is hard to track, and there may be the possibility that other providers may end up using services that might not have technically been referred to them, and that would be quite difficult. But unfortunately, from a Medicare point of view, that is how the current care plan is working. And the reporting back requirement, so allied health professionals must still report back to the referring GP after the first and the last session. However, that is not relevant for us in terms of our billing of reviews for 967. So you can still complete your review if you haven't had your allied health professional provide feedback back. However, obviously it is better for clinical practice, but in this case, not necessary. Then on the left-hand side, you'll see we've got some QR codes that you're very welcome to use. So with our health pathways for both Hunter and New England and Central Coast. So these are direct links to the chronic condition management plan information pages that have been created by Health Pathways. And then you've got a link there directly to my site as well, which will be able to allow you to have access to all the resources that I've talked about tonight. If you want to have a look at some of the free courses that we have there too. We have courses that literally cater to everybody, so GPs, nursing staff, and practice managers. Not so much for the allied health, but I do have a few allied health subscribers as well too. So we're going to open up the chat at this point for any questions. Michelle, have we got anything that's popped up?
So we haven't yet, but that's okay because I've got like 100 questions. So
Good.
I would like to share, the opportunity to ask questions though. So it's not just me. So I do really encourage people to pop things in. There is no such thing as a silly question. This stuff is all really complex. And Ashley's an absolute expert. So thank you for running through all of that with us. I was actually thinking as you were talking about the issue with not being able to not having to specify either the name of the allied health professional you're referring to or the number of sessions. And it's analogous, isn't it, to the Medicare stance on private specialist referrals, which has the same sort of idea behind it now, which is that it's the patient's choice, and referrals to pathology, radiology, and things like that. That we're increasingly encouraged to have those conversations with patients. And there's another element about sort of.
Oh, I've lost you. I've lost you, Michelle.
Oh, am I back? Sorry.
Yeah, you're back now.
Okay. I was just saying about Medicare literacy and having those discussions with our patients about, it's their Medicare rebate. What is it? How much is it? And where they can use it. So I think this is sort of the way that the ecosystem is moving, I suppose. A couple of questions. Common question amongst GPs, which you did touch on, but what are the very specific reasons for 965s being rejected? Have you got anything?
I've got a list. So essentially, if your 965 is being rejected, the first thing I think about is, when was your last 721 or 723 or 732? So when was the last review or care plan that you've done? So the rules still do apply. So you still do need to have that 3-month gap between the two. So if you've done a 732 a month ago and now you've thought, oh great, it's a new time, we can just start our new care plans straight away. No, you can't. So that would be the first thing, is checking when was it last done. The second thing is whether the patient has been registered with you for My Medicare. So if you can see on your system, okay, yes, they are registered for us as My Medicare, I would encourage a lot of the time practice management staff to actually log into Proda to see if the patient is still registered with your practice. Unfortunately, there is no easy and simple way to search this up. It really is through Proda at the moment, typing in your patient's Medicare information and seeing what they registered. If they have been registered with another practice, there is a reason for your exception. One of the other reasons that it could be is that the care plan could have been done at another practice if they're not My Medicare registered. So they might have been at another practice. If you have access to your My Health record, which most people do within BP particularly, you'll be able to sort of generally have a look with your patient around where the Medicare billing has last been done. And normally, me personally, before doing a care plan, these are the things that I think about, is when was the last one I did one, if they're my regular patient. If they're new to me and they become my regular patient, what does their My Health record look like? And having a good scream through there about where are the other chronic management disease item numbers at. And then if not, if all else fails and their My Medicare is not registered with your practice, there is your other reason as to why.
That's great. And I think we've had quite a few queries about this at the PHN, and sometimes it's been that the GP is not correctly listed in the organisation register in Proda, or they're listed under the incorrect provider number, or a practice has multiple locations and they're listed at a different location to where the service was provided. So there are a few sort of pitfalls to be aware of. So I think it's just worth just maybe flagging that there's a whole load of education about being able to run the organisation register on Proda correctly. It's not completely straightforward, but Services Australia has got a whole load of education on that. So we have got some other questions. So we'll have a little bit of a chat about some of the allied health stuff. So are there still only 5 allied health visits in 12 months?
Yes, that is definitely still the case. Yes.
Yeah. So I've heard a little bit of this. Oh, I've had 5 visits and now I get a new one of these plans, the GP chronic condition management plan. I'll get some more. No, sadly, there's 5 in 12 months, 12 months, calendar months.
Yeah.
And the only people that get additional sessions, so you still get 10 if you have a 715 Aboriginal and Torres Strait Islander health assessment. You don't have to have a 715 and a GP chronic condition management plan for that. Is that?
That's correct. You don't have to, but
you
I
can.
mean, quite often you can, yeah, and you should really.
Yeah, you should.
A lot of
Yeah.
the time they
Yeah.
fit that criteria, so definitely. The other thing that
Yeah.
often gets missed is about the 8 sessions that are available for those who are diabetic of having the group
Yes.
sessions.
Yes.
And these are rarely used, or I find if you don't know if you have a dietitian or an exercise physiologist around who do group sessions for diabetics, find out, because it might be a really good financial alternative for patients who, one, kind of want support in their disease, and two, can't really afford to have private allied health quite often, but really desperately need it. So those with a GP chronic condition management plan and are currently a diabetic can access up to 8 of these sessions. And so find out your local person. I found out we have an exercise physiologist the other week, which was exciting, that does the group diabetic sessions. So there are a few allied health guys out there.
Yeah, and that's a great resource. I mean, I think there are some complexities for allied health sometimes, in that you have to have a minimum number of people there to be able to build anything, and so there's a bit of organizational stuff around it. But yeah, exercise physiologists, dietitians, and diabetes educators, I think, can provide
Yep.
those services. So yeah, and that's a great resource. Okay. So we've got some other questions. So can everybody with a mental health condition now have a chronic disease, well, a CCMP, as even if the patient has a mental health care plan for the same condition? Good question.
Yeah, I mean, this is a good question, and my understanding is they could always have. And so quite often when we're seeing patients and we're seeing them for their mental health conditions, and they may, quite often it's complex, and there's a lot more than just, straight up adjustment disorder or straight up anxiety. We might have an eating disorder component. We might have a PTSD component. We now may end up also having a bit of hypertension in the background, or something else that's also happening for these patients. And so, yes, in my belief, you can. The most important thing isn't about, can I, just because somebody has a mental health care plan, also do by default a CCMP? Well, you need to actually fit the criteria for both of them. So obviously for a mental health care plan, that's not really the scope of tonight, but you can have a look on Medicare or have a look online and on my site and see what the criteria are for a mental health care plan and who fits that criteria. But however, in terms of a CCMP, as long as you feel that, one, they have a chronic condition that is going to last for more than 6 months, or has already lasted for 6 months, and they're going to benefit from that coordination of care that you're going to do during that appointment of a CCMP, then absolutely they fit that criteria. That would be
Yeah,
that
great.
would be my answer.
Yeah. And there's a related question to that about if you have a mental health treatment plan and you've used all 10 sessions for this calendar year for focused psychological strategies, can you then have 5 allied health visits from a chronic disease, a CCMP? I will get with the lingo, sorry,
So hard.
for the same psychologist. So that's a
Yeah, you
question I've been
absolutely
asked a few
can.
times. Yeah,
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 definitely. And I have done that, especially for those people who just can't afford to be paying privately after their sessions run out. And it is a little bit less of a rebate than what they get through the mental health care plan, about $20 less, but it's still a rebate that they might never have accessed before. So
and of course, if someone's actually met the extended Medicare safety net, then they will be getting 80% of all their gaps back anyway. So
exactly.
particularly towards the end of the year, if someone has used up 10 psychology sessions, they have an ongoing requirement for psychology, they meet all the other criteria, then it can be quite a cost-effective way for patients sometimes to access those sessions.
Yeah,
Um,
definitely.
so I'm just answering, sorry, a question on there about, is it do the 8 group sessions cover physio for people with type 2 diabetes? No, they don't. Diabetes educator, dietitian, and exercise physiologist is the only ones that are covered with that. Okay, let's have a look. I've answered that one. Are there still any? So when I raised the idea of a GP CCMP, apart from access to allied health, what other tangible advantages do patients get from a GP CCMP?
Can I get a repeat of that question? Sorry, that went.
Yeah, sorry, I did do it quite quickly. So so apart from access to allied health, what other benefits are there to patients of having a
Oh
GP
yeah.
chronic condition management plan?
Oh, I mean, Michelle and I were talking about this just before the session. There's such a big advantage, and there's an advantage that I'm going to split it by patient and GP. So in terms of the patient, there's good reasoning and there's good evidence for doing this sort of management-based care with a patient so readily every sort of 3 months that we can actually have a look at their whole picture. So you might have, like I was saying to Michelle, I might have a patient that has had, this crumbling CKD, and okay, where are we at? Are we winning anywhere with our protein? How are we going? Are we seeing the nephrologist? Are we seeing the podiatrist? What's happening there? That you almost forget that this patient has had rheumatoid arthritis for 20 years, and then you can see during that time during a CCMP, hey, how is that actually going? And then all of a sudden you start to notice, oh, hang on, their symptoms are back, and we've not done anything, and they've had this for a year, and I don't want this to get worse. And so that's a really good opportunity in these appointments to do that for the patient. The other thing I find as well is being on top of Medicare billing. It really allows a lot of my patients to be bulk billed a large percentage of the times that they see me per year. So being able to know how to bill and being able to bill effectively, especially around care plans, and knowing when you can do your reviews, it saves your patients a lot of money that otherwise they would be paying privately, and quite often the rebate is substantially better than most private fees for the work that you do during that time. So for me, that there's that. The other, obviously, allied health is a big one. There's the changes that are going to come with the Medicare, the medication review, so being able to access pharmaceutical care. But for me, it's also about initiating the ability to have 10997 opportunities with our nursing staff. And so 10997 is a nurse-initiated task that's done within general practice that supports the chronic condition of a patient. And so having and listing in your CCMP about, having your nurse do vaccinations, having your nurse help out with an ABI, an ECG in that 6 month mark that you want to see, or whatever it might be that you're doing, that is attracting further billings for yourself, your practice. And it's also an initiating more contact with your nurse. And quite often, I mean, any of us in GP know that practice nurses are worth their weight in gold, and we wish we could all have more. But using and utilizing this number really just reiterates to your practice and management of practice why we need nurses during our time and what we're caring for. So that's one of the other really big things that I like to do. I also note that having a look financially as a GP, being able to do these care plans quite readily, using co-billing opportunities that happen at the same time, whether that is a health assessment, that is the 10997, whether that is organising a medication review that now you've got the ability to bill a 900. These are all very serious financial gains in general practice, and is the difference between struggling and really thriving. And I feel there's so many reasons why I love CCMPs or care plans, but that's mine before I go and blow it out of proportion. But that's my summary.
Thanks, Ashley. I like that you've broken it up into, different benefits for you, for the practice, for the patient.
Yeah.
I mean, I would say I believe in care planning, as opposed to always being reactive. And look, it can be really challenging when you're dealing with 2 or 3 different things in a consult to be able to go back, as you say, and go, actually, where are we with the osteoporosis? Where are we with that? It's hard to remember to do everything all of the time. So I value that sort of structured approach to be able to sit down and to make some goals with a person, and also to involve them very much in that process. So and I think what you said about the nursing items, they're often a bit overlooked, the 10997s, but also the video and phone
Yes.
version of those, where you can do that that check-in if you've written it down and you've made the plan to do that in your CCMP, then you can have that programmed as another contact with the patient, which I think can be really valuable. And also the Aboriginal and Torres Strait Islander item numbers as well. I know we're not particularly talking about those today, but they're also a valuable service for people, I think.
Definitely.
And we got a couple of questions about the medication review changes. So, well, the first thing that changed with DMMR medication reviews actually happened already this year, didn't it? In January, when they really simplified the eligibility criteria, which I was delighted by. I didn't have to count
It's so good.
how many medications. I know counting, sometimes it's not the thing.
It's hard.
It doesn't sound very hard, but sometimes counting to 10. Anyway, so I think they really streamlined the eligibility. So now an awful lot of patients will be eligible for a medication review. But then there's also this other part of it, isn't there, Ashley, that you mentioned before about yeah.
So essentially from July in 2027, the patient will need to have a CCMP that's active for you in order to initiate the process of a DMMR. I mean, like you'd mentioned, the criteria becomes so much more simple that, they've got a chronic condition or they're not having great, medication is not working. It's not doing what it's meant to do. And they're essentially the only criteria that you have to meet, and you can meet one of them, not the other if you need to. And so that's really quite helpful. I mean, also just a plug to those who do medication reviews and the pharmacists that go out and do the medication reviews. They are just gold. If you get them done, you find your pharmacist. I have my pharmacist and he is fantastic, and I send him all of my medication reviews, and just the reporting that comes back is so good, that you just think, oh, I feel like now I've done a little bit more of the job. And so find your pharmacist is my recommendation. And then and figure out a way that they'd like you to refer your patients to them, and get that happening, because they are a very underutilized item number. It's also simplified the process at the end for claiming the item number now. So before, we used to have to do a physical phone call to the pharmacy to say, hello, I have done the medication review. Here is my report. Have you got it? Whatever that might be. And now it is as simple as just some sort of formal communication, which for me, I have a template that I email back, that says, this is the medication changes, this is what we discussed, and these are the changes that you'll see in Mrs. Smith's medication from forward on. And so it is become substantially more simplified. If before you had looked and said, oh, that is too hard.
Yes, definitely agree, because previously you had to schedule that time in to have a conversation with the pharmacist, either by phone or face to face. And so just not needing to do that and being able to do the written communication has been a real bonus. And I would say the same thing. I have a pharmacist that I work closely with, but they're limited by they can only do 30 a month. I think that's as many as they're allowed to do. So I mean, I don't get anywhere close to that, but it's a really, I find it a very valuable thing. I am aware that accredited pharmacists doing this work are quite thin on the ground, partly because, it can be quite challenging, I think, to make it into a business model. But there are, somebody was asking, I think Daikut was asking in the chat, that we don't always have access. So I know that there is at least one company that does this. Now I'm not completely sure of the details, but I know that they are on sent referral. You can make a referral to, I think they're called DMMR Australia, and they do have, they have other ways of being able to deliver this service in some circumstances. So that might be something to check out, but it's probably outside the scope to go into more detail about that on this one. But yeah, DMMR is a helpful thing, particularly post-discharge from hospital, and
so good.
Those complex patients. So I've had a couple of people have been picked up having taking loads and loads of vitamin B6. So that's topical at the moment, isn't it? That I might not have found out without that pharmacy review, which then, bring out everything from your cupboards, all of the tablets that you're taking, all of the supplements, creams, lotions, potions, eye drops, everything. So I think, that's where some of the value lies.
Definitely.
Let's have a look at some of these questions. So, bear with me a sec. So, hang on, new question. What platform do you use for telehealth for GP CCMP? I'm not sure whether that's about video or other things. So there are some, we can't do CCMPs by phone. We don't have an item number for that, do we? But we do have a video one. Do you do any of those by video? Do you do many of them that
Yes,
way?
yeah, I do. I do have a few. I mean, we mostly use, in terms of the video platform, if that's the question that you're asking,
That's the question,
we
yeah.
do have HotDoc that has the built-in video component. Otherwise, I have before we had this set up, I did actually use the Go-To platform. So this actual platform that's being used tonight, because I'd done a little bit of a deep dive on what was the most privacy, most compliant in health for Australia, and Go-To was one of the only ones that was listed at that time. So and it was free, and it's free. So and quite easy to get your reception staff to just send your patient the link. They sit in the wait room. You admit the one that you want to have come in, and then you see them on video, and it's essentially done. So there are some alternatives that don't include paid software, but those are the two that I've used predominantly.
I think Health Direct is another one. I also have used HotDoc and also AutoMed. We just got to be careful that we're not using platforms that are not designed for health use. Certainly, we shouldn't be using things that are for normal everyday use, but not for health use. And I suppose a related technology thing is about maybe using AI and things like that to try and help us with some of the documentation requirements of these things. Are you doing any of that, Ashley?
Yeah, so I am predominantly, I've seen to Michelle beforehand, I would say I'm practically 100% AI now. So everything I do is somehow AI generated. I use Lyrebird. I don't have a single affiliation to Lyrebird, but I love the product. And anybody who's ever done any of my courses or coaching knows I talk about Lyrebird and my templates. So if you are online and see any of mine templates, they were all created by me for a labor of love, because every time I would find something that it was missing, you can actually create it. And I find it creates incredibly good care plans, incredibly good health assessments, it's brilliant. Even letters to write back after my medication reviews are completed by AI now. So I don't think it does start, when you do start, you do need to put a little bit of effort into it and customize it for yourself. But once you do, you will never go back.
And it's important to know, isn't it, that as long as the documentation's there, there's no requirement to use the particular templates that are provided by the medical software companies,
No.
where we used to spend a lot of time filling out templates in Medical Director or Best Practice. It's not actually required for Medicare. So as long as it's fully documented and you've hit all your MBS requirements, then that's all good.
Yeah.
Yeah. Okay. Did we touch upon billing a 10997 as part of creating a GP chronic
No, but
condition
we
management
will.
plan? Yeah.
So
That's
Medicare is very
something that keeps
specific.
coming round, isn't it?
It does. I love
Keeps
it.
coming up.
I love going into practices, and people have been adamant that they absolutely can, and I absolutely can't. So you cannot be billing a 10997 for the creation or the review of a care plan. So any of them cannot. The function of reviewing and creating a care plan is not going to be able to be considered a nurse initiated task. The reason why is it's not what the role of the GPMP see, I did it then, the CCMP, or the review is for. It's a GP item, so the item belongs to the general practitioner. However, if your nurse is actually doing activities that are related to chronic conditions planning and are relevant for the care, so that might be immunizations, prolia, B12, they might be doing an ECG at the same time, they might be doing a health assessment that's relevant, or they might be doing, some sort of my aged care referral for you that's a part of the process, then that does attract a 10997. However, make sure that documentation wise that's been very clearly specified as to what the practice nurse is actually doing to claim that 10997, because Medicare, since our changes, have been really specific about this and have even provided us with like a little Q&A section, which was very new for them, but they did. And one of those specifically is about, can I claim a 10997? And the answer is no. So if you are, and I do often get asked, how do I get around that? The nurse needs to be doing some sort of other activity. And this is, for me personally in practice, is where I've started to say, okay, it's time to move even more into AI for care plan creation and review, because our nurses' time is no longer going to be beneficial financially on spending a half an hour creating a care plan, when it's much better of an idea if I have them doing an ABI, another health assessment, something that's more financially viable for the practice during that nurse's time. So personally, that's what I've started to do.
Yeah, so it firstly needs to be identified as a need in the care plan. Is that right?
Correct.
Yeah, initially, and
Correct.
then when it's actually delivered, it has to be clear in the record what was delivered that was separate
Yep.
to
Yep.
the information gathering or other types of processes around the care plan.
Exactly right.
Those
That's
are the
right.
two biggies in that. Yeah.
Yep, they are. Yep.
And another question I've got is about transition arrangements for allied health. So there's been a bit of talk about, you had an EPC and now it's the 1st of July has passed, and so now you need a different piece of paper to be able to continue to access your 5 allied health sessions this year. Have you seen any of that? I've heard a few rumblings.
I have heard of a few. I think it's just from a place of confusion. But essentially, that July 2027 is our date, and that's our transition date. So essentially, what that means is patients who are accessing allied health from previous care plans are still able to access and use such sessions from that referral up until the 30th of June 2027. Once we go over to July, essentially they need to be on the new care plan created item numbers, 965, 967, whatever that might be. And that is what they need to really be doing by this point to gain access to their referrals after that date of July 2027.
Yeah, great. So there's no additional paperwork needed now. The EPCs as they were, still valid. But now when we're doing a new care planning service, we're using the new item numbers. And there's a question there, do we need to wait for a 12-month time from the 721 before we can do a 965?
No,
Do you want
so
to talk
3
a little bit
months.
to that? Yeah. So
Yeah.
anybody,
So yeah. No, that's okay. I'll go. So essentially, from 3 months from the previous care plan, you can actually create the new one. So I have said, educated said most people about saying that these first 3 months, you should only be billing a 965, even though that would be an appropriate time for you to be doing what you would think is a 732 or a review. You're actually going to start the new care plan process, which would be doing the 965, so that it allows you to complete reviews of 967 from there on afterwards.
yeah, great. That all makes sense. It's complex, isn't it?
It is.
And what
It is.
about
Yeah.
item numbers that can be co-billed? So there's a bit of interest in the new menopause item number. Can that be co-billed? Are there other kind of easy to remember rules about what can and can't be? If
Yeah,
it's appropriate,
absolutely.
of course. We're only talking about
Of course.
clinically relevant services at all
Yes.
times.
Absolutely. Clinically relevant and completed minimum requirements of each Medicare item number.
Yeah.
So, yes, there absolutely is. And whenever I think about item numbers, I place them into general attendance and not general attendance. So, our general attendance items are your 23, 36, 44s, number 3, whatever that might be. So, the general attendance item numbers in these cases, do not think about co billing these item numbers with your care plan unless something so specifically it has come up that you can fit that criteria. I will touch base on that towards the end. The other item numbers are more of an opportunity for you to be co-billing those item numbers together. So for instance, mental health care plans, mental health care plan reviews, heart health assessments, which is 699, the menopause assessment, 695, other health assessments that might be age related, at risk of diabetes, 40 to 49 at risk of chronic disease, those with intellectual impairment, those who have been discharged from the RACF, at that once time. So those 705, 707 item numbers can also be co-billed with your care plan. So those can be done as long as they fit their time requirements. So a health assessment such as 705, 707, they're specific time-based health assessments. So have a look at those and see what the time requirement is for that. However, your 699, your 695, both have a 20-minute minimum time requirement. So that during that time, that is when you'd be needing to make sure that you fill the time requirement of that particular item number. Care plans themselves, or CCMPs, do not have a minimum amount of time required to have that conducted. So for you, if you have completed the consult and your actual creation of your care plan has only taken 30 seconds thanks to AI, then that is okay if that's the time that you have claimed as your care planning, when you've otherwise been speaking about a whole bunch of other things that's actually really ended up being your care plan. So in terms of co-billing items, general attendance is a no. Almost every other health assessment, every other mental health care plan, 715s, etc., are all co-billable. So quite often, think about those times and thinking about the patient that's in front of you. You can bill them at the same time. You can also just wait until another appointment if you decide you're going to do a 707 with this patient, or you've got a mental health care plan and you just don't have time to do it at the same time. That is okay. You don't need to just stack them all on at once. You can spread them out if you need to. However, if it does arise that you've done the care plan, you've also done a mental health care plan review so that they can access more sessions, and you've also completed a 695 menopause health assessment in a 25, 27 minute appointment time, that is fine for you to be co-billing all of those item numbers together. Another set of billing item numbers that can be billed with this is investigations. So ECG, beta HCG, spirometry, ABIs, etc. They can be billed with almost with any item number. And so you can have that during that time.
Yeah, great. So it's mostly the general attendance item numbers. And what about that you can't co-bill, just to be clear. And what about sort of documentation requirements time-wise? Do things need to be time-stamped? Do they have to be recorded in a separate note? What sort of advice have you got about that?
Yeah. I normally, if you do have AI, you can actually get AI to record how long you spoke about that item number for and pop it in a brackets next to your notes, which I find is really helpful for me. Otherwise, time stamping is another really good option, because when it comes to billing and those item numbers that have time requirements, you will be required to put in a time amount of start time and end time, so that you'll be able to see exactly how much time you spend in that consult on that particular item. So say, for instance, if we ended up having a care plan created for someone with hypertension, and we've also done a 699 or the work of a 699 during that entire time, and we fit that criteria and they also fit that criteria, then what you end up having is you might have an appointment time that goes for 21, 28 minutes, whatever that might be. And you might say that 8 minutes was the care plan component around hypertension, and then the remaining 20 minutes, so say from, at 1 o'clock you started the appointment, at 1:08 you started the 699, so you'd put in 1:08 until 1:28, so that you fit that 20-minute criteria. that's how I would recommend time stamping it, just around, if anything, helping prevent exceptions from returning.
And what about when you're actually submitting those to Medicare? Any
Yeah.
any tips on annotating?
Yeah, so the biggest thing around annotation is making sure that the Medicare can understand why two item numbers have been done at the same time. And the biggest thing is about making sure that they know that it's not relevant to the other item number. So quite often, I find we annotate by saying not related, or not, or somehow clinically relevant to the consult that might be completely separate. It each to their own, however, but most commonly we tend to use not related. So that first time, that first part of the item, that 965, and then you've got a 699 again, which is not relevant to the topics that you've discussed in that first part of the consult that is related to the 965 number.
So another question, which is about eligibility, really, it is about, is obesity classified as a chronic disease? Now, my understanding is there is no list of things that are in, things that are out. It's all up to clinical judgment, and you have to be able
Yeah,
to defend that against your,
yeah, yeah,
a
and it's
panel of
really hard.
peers, I suppose, and pass the
Yeah,
pub
yeah, it
test.
is. Exactly, the pub test, and it's really, really hard. So I mean, they have also specified, since the creation of the 965 item number on Medicare MBSs online, that you'll be able to see that they have said, what is a list of chronic conditions? Can this be on there? And they say, we do not have a list of chronic conditions. You, as the GP, will know whether their condition is chronic and that this patient would benefit from a CCMP. A word to those who do put obesity. I think this might be from my first, from the GPMP days of sort of being wary of what am I going to list as the condition or multiple conditions. And I mean, obesity is definitely one thing, but quite often I find clinically a lot of people are misfitting the metabolic syndrome criteria. And even though that they might actually fit the criteria of obesity, would I personally choose to do a care plan based off someone being obese? Probably not. No, because I think there would be other things involved. That might be hyperlipidemia, that might be hypertension, that might be pre-diabetes. They may have PCOS, whatever it might be. Just seeing a patient once and not, investigating or doing other sort of things that might be relevant for their care, and just listing it as obesity is probably just not in my ethos personally. I don't know about you, Michelle. What do you think?
Look, it's probably more in risk factor territory than disease territory, isn't it?
Mm,
It is a grey area, and so I think
mm,
it's a case by case thing. And as you say, a lot of people will have other things. A lot of other things coexist, whether it's disordered eating, whether it's metabolic liver disease, all these other things. So
mm,
I think it really it depends as much as in general practice, I'm afraid. Sorry, that's
mm.
not a very concrete answer. Um, if you do spirometry for asthma, does the result discussion count as part of the spirometry item number?
Oh, that's a good one. No, from my understanding, no, it doesn't. The spirometry is the action and the activity that was
Mm.
completed. So if you're seeing a patient, and then you're going through it, and then that you're talking to them about their asthma management or changes in inhalers or inhaler technique, no, I don't think that's covered under the spirometry item number. That would definitely be a clear 23 or a clear general attendance, in my opinion.
And that would be the same for an ECG or a pregnancy test and those other sort of common
Absolutely.
investigations that we do. It's really the item number there is for the diagnostic procedure and investigation. And then if there's a consult, then that's actually a
Separate.
separate item. I think this distinction between general items and general attendance items and other item numbers is going to become front of mind when we hit November as well. And because some of the things around bulk billing incentives, um, that only are going to apply to the, as they do now, to the general attendance item numbers and not to other item
That's
numbers. I
right.
think that's going to just solidify in our minds a bit what the difference is between
Mm,
general item numbers. Obviously, there'll be expanded eligibility patient-wise, but the numbers the actual item numbers that are eligible, that's my understanding, are unchanged. Is that right,
That's right.
Ashley?
Yeah, that's right.
Yeah, okay. Because there's a little bit of complexity there as well, because there's the triple bulk billing incentive expansion into to apply to the whole population, essentially with a Medicare card, and then there's the bulk billing incentive payment, which is related but different. I know this is slightly off topic, really, but and unless you all ask me more questions, I'm going to carry on this line, because we're pretty much have covered all of our questions there. So did you want to venture into that a little bit, what that involves?
Yeah, I mean, I sort of say be wary of it, because November he's not here. And even though we've got some, some ideas around what's going to be, what we've got around that triple incentive, and then the incentive payments as well, for a practice, what that looks like. I think everybody's done the maths. Could I be predominantly or 100% bulk billing? What would my finances look like that? And everybody needs to do that for themselves. I suppose I always sort of recommend having a little bit of a look at what that will look like in the future, is that it just covers those general attendance item numbers. So those health assessments, care planning, etc., are not going to be covered in those incentives. And so making sure that you don't essentially triple what your bulk billing income has been, and assuming that that will be under the incentive. And I would say that, so proceed at caution is my general summary at that one. But when that does come out, and what that looks like, I'm certain there will be some sort of webinar with the PHN that I feel like that we'll be having this conversation closer to the time, and what that will look like. But yes, that's my 2 cents.
Excellent. Now, I don't know why, but I seem to have disappeared.
You've gone.
So I'm still here, but
You're
my
here in
camera's
spirit.
still on. So I'll just be a disembodied voice now, because I just tried to fix it and I can't. So yeah, so my understanding about that is so there's the triple bulk billing incentive, and then there is the separate bulk billing incentive to practices, 12.5% based on eligible item numbers, 50-50 split, 50% going to the GP, 50% going to the practice, and I think very wide practice criteria in terms of accreditation requirements and things. I think there is a bit of leeway for non-accredited practices at the beginning of that. So anyway, it will be interesting to see how that all pans out. And yes, I'm sure we will be on the front foot with more information about the technicalities of it, really, and the detail a bit nearer the time, I think. Not necessarily in webinar format, probably more communications coming out about that, I would think. Another couple of changes flagged for November, I think, are there, Ashley, about the mental health item numbers? Did you want to just touch on that? I mean, I haven't seen anything recently, though.
Yes, so I have not seen anything recent either. So we are also still in limbo land around this. And so from what our understanding is at this time, is there may be some changes to the criteria around mental health care planning and simplifying the referral component of it. However, the biggest concern and likely change is the removal of the review item numbers, and having reviews for mental health care plans being covered under general attendance, which is it is a bit unfortunate and difficult, because quite often the reviews are a really great opportunity to co-bill with a lot of item numbers, and another incentive to get in touch with your patients that may have their mental health issues have resolved. However, having that now is sort of going to be just a part of general attendance, rather than looking at having that review item number as well.
Okay, and I suppose that there's been a few changes recently along the same line. So there was the ending of the COVID-19
19.
immunisation and counselling kind of item numbers, wasn't there, that finished fairly recently. But then we have these other new item numbers, I suppose. So anyway, that's just to keep people aware of, so that they know there may be more changes coming. Again, I'm sure there'll be more information comes out
We'll
closer to the
definitely have more.
time.
Yes.
Yeah.
Yep. Cool.
So we've got about 5 minutes left. We're out of questions for now. Have you got any other thoughts about things that kind of come up commonly, or questions that come to you a lot that we maybe haven't touched on?
There was a question for a practice that had mentioned that they had 2 sites, and they were having trouble around their My Medicare registrations, having patients being seen at both sites, with providers that across both sites with different provider numbers. And I really had to think about this, and I really had to look at it, and unfortunately, it seems as horrible as it sounds, that your patients are going to need to essentially have a hub or a home practice for them where they see that particular doctor rather than being at one site. There has been talks, I have heard of other practices having a CDM home or a chronic disease home where their patients get most of their care planning and health assessments done at the one site, and the other is conducted a little bit more differently, whatever that might look like, which is really difficult. But for those practices that have the 2 sites, and are in that My Medicare situation, at the moment there is no answer for this, and it is something that hopefully we will find out a little bit if there's some flexibility across these practices. But it would be a very difficult situation.
So that's to do with the physical location and provider numbers
Mm-hmm.
being recorded separately in the My Medicare organization register, and it's a
Yes.
kind of, it will be computer based logic that then means it's not possible, I suppose.
It's not right now, but yeah,
Yeah.
that's the thing. It should be, and it makes sense, but unfortunately, they haven't really counted for practices that operate this way.
Okay. Well, thank you for that. Any
Mm.
other thoughts about all of this chronic condition management plans? I suppose my only other thought is that actually there's loads of people that are eligible that were never eligible
Heaps,
before,
heaps,
specifically for allied health. And I think that's a really,
absolutely.
that is one positive thing that's come out of all this change, is that instead of needing to have those 2 extra providers, I've got a whole range of people who are now eligible for a bit of subsidised allied health. And we could get into debate about whether that's enough or not, but at least they're eligible
Mm,
for some, whereas they weren't before. So that,
absolutely.
and not having to send team care arrangement paperwork left, right, and
Dream.
centre has been a positive thing. Yeah.
Definitely. No, I agree. I agree with you. I quite like them. I think they're much more simplified. They make sense. It's probably the first time we feel a little bit less admin heavy, which is nice. And yeah, and ultimately, if they're done well, they still benefit the patient quite a lot. And if not, by accessing allied health before, no, you just don't fit that criteria.
Yeah, great. Well, thanks so much for coming and sharing your
All right.
expertise with us. It's been really fantastic to pick your
Okay.
brain and to be able to talk through some of those things. I don't know, Jenny, do you have some final housekeeping and things that you need to do?
Thank you so much, both of you. It's been a very engaging session. No, I don't think I have. The only other thing I will mention is that there will be an evaluation will pop up just with some generic questions. Takes about 30 seconds to complete. If you could all complete that, we love to get your feedback. And I will try and upload the recording tomorrow. So thank you, everybody, and thank you so much for being so engaging and asking lots of questions, and I'm sure that you all got a lot out of it. Good night, and thank you so much, Ashley and Michelle, for giving up your
No
time.
worries. No worries, guys. Good night. See you
Thanks,
later.
everyone.
Bye.
Bye.